Hello friends, welcome back to the channel. Like, share, subscribe and don't forget to press the bell icon. The clinical manifestation of HMPV infections are distinguishable from those of an RSV infections, especially in young children. HMPV in patients are generally diagnosed with bronchitis, bronchitis and pneumonia. They show common symptoms like fever, cough, hypoxia, upper respiratory tract infection, lower respiratory tract infection, and wheezing. However, the most common cause of hospitalization are bronchiolitis and pneumonia. The average duration of fever and in HMPV positive cases is about 10 days with a peak during the course of the illness. Young adults with HMPV reinfection show mild cold and flu-like symptoms with fever in a small proportion of infected cases. However, in the case of elderly patients, reinfection can lead to severe symptoms such as pneumonitis and even to death. One more than 50% of children with HMPV infections were diagnosed with otitis media, and another that HMPV infected was found in about 8% of children who come to hospital with wheezing. Wheezing is a common clinical symptoms observed in multiple studies of children with HMPV associated lower respiratory tract infections. HMPV infections can lead to asthma exacerbations in small children and adults. HMPV acts as an enhancer of COPD, and patients with COPD are more prone to HMPV infection. The HMPV infection in children may be associated with a spectrum of central nervous system disease ranging from febrile seizures to cerebral encephalitis. HMPV was detected by real-time RT-PCR in asymptomatic children, but they had significantly lower viral loads than those found in symptomatic children. Higher HMPV viral loads were significantly correlated with the course of illness and disease severity, irrespective of genotype. Higher levels of HMPV viral shedding lasted from 1 to 2 weeks after acute illness. HMPV associated fatal pneumonia has been indicated in the case of a child receiving chemotherapy for acute lymphoblastic leukemia. HMPV was found to be a solo etiological agent responsible for the fatal infection of an allergenic hematopoietic stem cell transplant patient, showing interstitial and intra-alveolar pneumonitis with profound alveolar cell damage. HMPV infection during the first week after hematopoietic stem cell transplant may be associated with much higher morbidity and mortality rate. HMPV can cause a range of illnesses in lung transplant recipient, from mild upper respiratory tract infection to a severe lower respiratory tract infections. In involving patient with severe motor and intellectual disabilities, the early stage of HMPV infections were characterized by a low to moderate increase in a C reactive protein, that is CRP level, reduced peripheral blood lymphocytes, and an elevated monocyte ratio. Although the peripheral blood lymphocytes and monocyte ratio normalized with the mitigation of symptoms, the CRP levels persisted for some times, along with elevated serum CPR level. A few hospitalized children infected with HMPV were also reported to have leukopenia and leukocytosis. Persistent infection by HMPV may be attributed to a minimal and late immune response, as well as delayed cytotoxic T lymphocyte activity with impaired virus clearance during primary infections. HMPV interferes with superantigen induced T cells activation by infecting dendritic cells. Thus, the proliferation of antigen specific CD4 plus T cells is restricted and the production of long term immunity is impaired. Respiratory viruses are known to modulate cytokine responses compared to RSV and influenza. HMPV is a less effective inducer of different cytokines like interleukin, tumor necrosis factor alpha. HMPV infection induced pulmonary inflammatory changes in mice and cotton rats and lead to an increase in the levels of interleukins, interferons, macrophages, inflammatory proteins 1 alpha, and monocytes chemotactic proteins in a bronchoalveolar lavage fluids and in lungs. These changes further lead to perivascular and peribronchial infiltrations and inflammations, the formations of intraalveolar foamy and hemosiderin laden macrophages, smudged cells, alveolar damage, and hyaline membrane disease are seen in immunological and histopathological investigation. It is known that the HMPV infections induces tool-like receptor dependent cellular signaling. However, the role of tool-like receptor mediated signaling in the host defense against pulmonary HMPV infections and pathogenesis is MyD88 deficient mice that shown to have significantly reduced pulmonary inflammation and associated disease compared to wild type C57BL6 mice after intranasal infection with HMPV. Various cell lines such as Vero cells, HEP2 cells, HEPG2 cells, 293 cells, and LLC MK2 cells have been used for the growth and isolations of HMPV, using 19 different cell lines to grow HMPV. The most suitable cell lines for the growth of HMPV were human Chang conjunctiva cells lines and feline kidney CRFK cell lines. In cell culture, HMPV has a slow growth rate with later cytophatic effects varying from the rounding of cells and the detachment from the culture matrix to small symptom formation. For this reason, the detection of HMPV antigen using anti-HMPV antibody in direct fluorescence or ELISA based assay is widely used along with cell culture method. The sensitivity and specificity of cell culture detection methods were found to be 68% and 99% respectively, as compared to real time RT PCR detection of HMPV. Currently, the use of cell culture for the diagnosis of HMPV infection is uncommon, and molecular method like RT-PCR and real-time RT-PCR are most widely used. Developed and evaluated multiplex PCR assays with the aim of providing a tool capable of detecting an increasingly complete panel of respiratory viruses. With the development of multiplex RT-PCR, that is MRT-PCR, is now possible to design a more sensitive and rapid assay for the detection of HMPV. MRT-PCR methods have a sensitivity and specificity of 100% and 96% respectively, compared to 54.6% and 100% for RRT PCR. The another advantages of MRT PCR is the ability to detect co-infections even with very low viral loads that are undetectable via cell culture or immunostaining. However, many clinical laboratories do not present have the capability to perform routine diagnostics RT-PCR for HMPV detection. For rapid and accurate diagnostics of HMPV infections, a combination of immunofluorescence assay and direct fluorescent antibody method is used as the first line of diagnosis, followed by RT-PCR on the negative sample. In the future, the ability of cell vial centrifugation culture and HMPV monoclonal antibodies will be of significant benefit for the rapid diagnosis of HMPV in clinical laboratories.